Hello everyone, hope you guys are doing good. So today we will be discussing about menstrual physiology part 1, which is a chapter belonging to the gynecology of final year MBBS. So let's start. Now let's understand the external genitalia. So external genitalia, we can see the structure of the female genitalia here. What are the parts? External genitalia comprises of the parts of the vulva. Now what is vulva? The clitoris, the labia minora and the labia majora. So the clitoris, the labia minora and the labia majora, only these three makes the part of vulva. If there is any misconception, then make it clear. Clitoris, labia minora and labia majora makes up the vulva. What are the adjacent organs? The vaginal opening, urethral opening and the anus. These are the adjacent organs. Urethra, vaginal opening and the anus. Uterus in coronal section. Now, this is a diagram in which we can see the uterus in the coronal section. In this, it is given the uterine length is 7 to 8 centimeter in nulliparous female. Now, what is nulliparous female? Nulliparous female means who didn't give birth to any baby. Multiparous means who have already been pregnant. So, the uterine length in a nulliparous female is 7 to 8 centimeter, but in a multiparous female it is 8 to 10 centimeter. That is, the uterine length increases. So this is the length of the uterus, which is the body of the uterus and the neck of the uterus. I mean the neck of the cervix, the whole thing, this much. Now what is the cervix? You can see the part of the cervix. This part is the cervix. It is 4 centimeter in length and called the neck of the uterus. If if the cervix is less than 2.5 centimeter, we call it short cervix or incompetent os. Okay, so this is very much important from the NEET point of view. Now, uterus in sagittal section. Let's understand this very carefully. Angle of the anteversion is 90 degrees. Now, I guess you know what is anteversion and anteflexion. It's already stated in the first year. Cervix point downward and forward. What is the significance of being downward and forward? The significance is let's understand this. See, if the cervix is downward and forward, now this is the downward and forward. Downward means this one, and forward means this one. So downward and forward means this part. So what is the significance of downward and forward? It helps for collecting the sperms. So cervix points downward and forward, which helps to pick up the sperms. Importance is it helps to pick up the sperms from the vaginal pool. Length of the vagina is anteriorly 7 centimeter and posteriorly 9 centimeter. This is the anterior length, which is 7 centimeter, and this is the posterior length, which is 9 centimeter. So 7 centimeter and 9 centimeter. This angle is called the anteversion, which is 90 degree. Okay, this particular angle is 90 degree. Now let us understand the part. Fornix. Two terms, fornix. Area of the vagina next to the cervix is called fornix. Now this is the vagina and this is the cervix. This particular area is called the fornix. Now in front, which is in front, that is the 7 centimeter guys. This is the anterior fornix, and which is at the back is called the posterior fornix. It's called the posterior fornix. This is also called the vaginal pool because the sperm mainly gets deposited here. The sperms get deposited here most of the time and picked up through this path. Let's go to the next slide. Fallopian tube. Now, what is the fallopian tube? You guys all know oviduct is called the fallopian tube. Initiation is from the intramural part. Now, this intramural part is a new term. We will discuss it later. Fimbriae is the clasp. You know what is fimbriae? It holds the ovary. Oocyte is caught here. These are the basic things, so I'm not giving much stress. Oocyte enters the fallopian tube and reaches the ampulla. Now let's understand the part first. This is the structure of a mature mature female female genital system, female reproductive system, in which we can see this part is the intramural part. Intramural part is the narrowest part. It is the narrowest. Remember this, it is the narrowest part. Intramural part is the narrowest part, 1 centimeter. Then comes the isthmus, which is 3 centimeter. Then comes the ampulla. AI junction is the junction where fertilization takes place. Ampulla is the 5 centimeter. Then comes the infundibulum, which is again 1 centimeter. There is a little bit problem in the diagram, but infundibulum is also 1 centimeter. Now fimbriae, these are the fimbriae, which is the clasp-like projections which picks up the oocyte when the follicle ruptures and the oocyte comes out during ovulation. So what we have here is the fimbriae is the clasp which holds the ovary. Oocyte is caught here. Oocyte enters the fallopian tube and reaches the ampulla through peristaltic movement of the fimbriae. That means peristaltic movement. That means ciliary movement is also there in the fallopian tube. These two combined action propels the oocyte through the fallopian tube towards the uterus. That means when this oocyte is coming, it is being propelled through the AI junction. Okay, it comes to the AI junction and waits for the sperm to come. Now, what are the part of the fallopian tube? Isthmus, isthmus is the narrow part, which is 3 centimeter. Intramural part is the narrowest, which is 1 centimeter. Ampulla is the widest, which is 5 centimeter. Remember this. This is very important. Isthmus is narrow, but intramural part is the narrowest. Ampulla is the widest. Ampulla is the site of fertilization. It is the most common site of ectopic pregnancy. This is very important from exam point of view, that ampulla is the most common site for ectopic pregnancy. These are basically totally details discussing, so you won't get much interest in this. Now, next common site for ectopic pregnancy is isthmus. Ampulla is the first most common, and then isthmus is the second most common. First most common is still ampulla. First most common is the ampulla. Now let's understand what is epithelium. So we were talking about the epithelium. Now, see, basically the female reproductive system is made up of various epithelium on the inner linings. Let's understand that. Starting from the vulva, which is the outside, it is made up of squamous epithelium. Moving upwards, it gets converted into stratified squamous epithelium on vagina, and then again squamous epithelium on the surface of cervix. Squamous epithelium. Now let's talk about the oviduct. The oviduct, the fallopian tube, it is made up of ciliated columnar epithelium, which coming downwards get converted into normal columnar epithelium. Now what is external os and what is internal os? I guess you know. The outside of the cervix is the external os, which is the external opening, and the inside of the cervix is the anatomical internal os, which is the internal opening. What is histological internal os? This is very important. This is a new term, histological internal os. This is that part where the histology changes. What does that mean? That coming from the fallopian tube, coming from the endometrium, the ciliated columnar epithelium changes into normal columnar epithelium. That particular point is called the histological internal os. Now, what is the significance of this histological internal os? We we are here getting a new term which is called the isthmus of cervix. This is important because later on we will be discussing on isthmus of cervix. What is this? The portion between the anatomical internal os is what? The inside opening. And histological internal os is where the histology is getting changed. That means this particular area. This particular area is what? Isthmus of cervix. This is very important. This particular area is very important. We will discuss it later on. Now, endometrium. Endometrium is made up of columnar epithelium with microvilli or ciliated columnar epithelium. Just now we studied that it's being continued from the oviduct. It has two parts. What are those? Stratum basalis and stratum functionalis. Stratum basalis is the basic epithelium on which the stratum functionalis grows. And what is stratum functionalis? It is that part of the endometrium which gets shed every month. That is the menstrual blood. Okay? It is that epithelium which sheds every month as menstrual blood. Now the isthmus of cervix, as I told, anatomical internal os and histological internal os. The space between is called the isthmus of cervix, and it is anatomical internal os made up of the ciliated columnar epithelium, and the histological internal os made up of plain columnar epithelium. Transitional zone or the transformation zone or the squamous columnar zone. What this is? This is important. As the cervix exposes into the vagina, the transition from the columnar to the squamous epithelium occurs. This one. As the cervix exposes into vagina, the transition of columnar to squamous epithelium occurs. These are active dividing cells. They can get acted upon by the papillomavirus, that is the HPV, human papillomavirus. It is the first site where carcinoma of cervix occurs. From NEET point of view, this is very important. First site where carcinoma of cervix can occur is the transformational zone or the squamocolumnar zone. Squamocolumnar zone means cervix to vagina. Okay, the cervix exposes into the vagina. This is the transformational zone, very important. This area, cervix to vagina, this particular area. This is the internal os of the cervix. From here, it's getting started and then going on. This whole area. Right. From here to here. Basically, this particular part, which is the most actively dividing cells. Okay, but that doesn't mean that this or this won't be affected. This can be also affected, but this area affects the most. These are the actively dividing cells, transformation zone. Okay, it shows abnormal cells. In this area, screening is done by pap smear. If you have the pap smear, you can do, and you can come to know that human papillomavirus have been attacking there. Now the isthmus of cervix, which I told earlier that it is very important, and we will be discussing it in the further slides. Now, what is the isthmus of cervix? It is the area between anatomical internal os and the histological internal os. This much we know. Now let's understand. For a non-pregnant uterus, the isthmus is of length 0.5 centimeter. That means this particular size is only 0.5 centimeter. In a non-pregnant or nulliparous lady. In pregnant lady at the time in labor, It stretches and becomes, the lower segment becomes 7 centimeter. This one. This particular diagram you can see, this particular diagram, this is the baby head and this is the baby legs. These are the baby's hand. So this one becomes 7 centimeter. The isthmus becomes 7 centimeter at the time of labor. It helps the baby to move downward by upper segment contraction and lower segment relaxation. What does that mean? That particular thing means that when the baby, means basically when the woman is in labor, the baby is tending to come out, and this upper segment contracts, the uterine wall contracts, and this lower isthmus relaxes. As a result, the baby could come out easily. Now, the isthmus was 0.5 centimeter and it's getting converted into 7 centimeter. You can see the changes. Now this black color, through the black colored pen, I have made a round here. You can see the circles. What are these? These are the physiological retraction ring. These are physiological retraction ring. We'll come here. Ring formation between upper and lower segment. What is the upper segment? This particular part is the upper segment. This particular part is the lower segment. This is the upper segment. This is the lower segment. So ring formation between upper and the lower segment, it is called physiological retraction ring. Very important. It can be felt only through pervaginal examination. Only through pervaginal examination. PA examination, per abdominal examination, you won't get it. Okay. So physiological retraction ring, how can you get? Per vaginal examination. Now, in obstructed labor, in case of obstructed labor, uterus contracts but the head doesn't move downward. Upper segment bulges and goes upward. Pathological retraction ring is seen, which is the Bandel's ring, move higher and can be felt in both per vaginal and per examination and per abdomen examination. So basically, in obstructive labor, let us see the diagram first. This is the obstructive labor, which is the abnormal condition. Here, what happens? It is a pathological retracting, sorry, retracting ring. Pathological retracting ring is seen here, and it can be observed through per vaginal as well as per abdominal examinations. One thing you need to remember is the Bandel's ring, the term. For the pathological retraction ring, the alternative name is the Bandel's ring. Ovulation. We all know what is ovulation. Let's once again recap. Life of the oocyte is 24 to 48 hours. That means 1 to 2 days. Okay. Life of an oocyte. If the oocyte gets fertilized, then well and good. Otherwise, totally degenerates. Embryo survives and reaches the uterine cavity on the day 3 to 4. What does that mean? See, first day ovulation done, it stays for 2 days. Let us consider the event where it is successfully fertilized. Then from the day 3 to day 4, it will just travel. Okay, it will just travel to the uterine cavity but won't get implanted. It will just travel, and also it will continuously divide. On day 3 it will divide to 8 cell stage. On day 4 it will divide to 16 cell stage. Implantation occurs on day 6 to 10. What does that mean? After day 4, it takes, you can say it takes time for day 5, and then on day 6 to day 10, implantation takes place. Okay, this on the secretory endometrium. So we all know what is implantation basically. In terms of the menstrual cycle, ovulation is on the 14th day. So if the ovulation is on the 14th day, implantation should occur on 14 plus 6, that is 20, and on the higher segment 14 plus 10, 24. So day 20 to 24 of the menstrual cycle is implantation window. That is the implantation period. So implantation window, the new term implantation window is in terms of menstrual period, it is 20 to 24 in terms of menstrual cycle, and in terms of ovulation cycle, it is 6 to 10 days. Ruptured follicle shrinks and become yellow body. Means basically we are talking about the corpus luteum. So ruptured follicle shrinks and becomes yellow body, which is the corpus luteum. It secretes progesterone, which helps in the maintenance of the endometrium. Makes endometrium secretory, helps in the implantation. Before follicle ruptures, follicle have oocyte. This is the structure of a follicle, mature Graafian follicle. Now it ruptures and the follicle makes estrogen from the granulosa cells. Okay, before rupturing, this is very important that before rupturing, before rupturing, estrogen is constantly being secreted from the follicle. Okay, till now oocyte haven't got out. And this estrogen is supplied to the body plus uterus all over, not only to the uterus, even to the body. After the rupture, the oocyte goes into the ampulla, and the ruptured follicle is now called the corpus luteum, which constantly secretes progesterone, which gets supplied into the body. Now, main function of the progesterone is to hold the endometrium, that is to supply the endometrium. The estrogen, it comes from where? It comes from the growing ovarian follicle. Helps in the proliferation of the endometrium. That means the endometrium is getting developed. In general, the follicles are available for 46 to 47 years of age. That is, after this time, no more follicles will be coming. Menopause we can see the menopause. For a 17-year female sexually inactive, that means what? Fertilization won't take place. The oocyte dies in 24 hours. We already told that the oocyte dies in the 24 to 48 hours. The follicle ruptures and shrinks into the corpus luteum. The corpus luteum secretes progesterone. Endometrium becomes secretory, and by 10th day of the ovulation, corpus luteum degenerates if pregnancy doesn't occur. Because pregnancy do not occur, hence progesterone levels start decreasing. This is very natural because the corpus luteum is being degenerated, so there is no one to control the progesterone anymore. And the endometrium shedding starts. Why? Because progesterone is no more there. Complete degeneration of the corpus luteum is 14 to 15 days. By the day 10th, it completes. By the day 10th of the ovulation, corpus luteum starts degenerating, but it gets completed by the day 14 to 15 of the ovulation. Of the ovulation, not the menstrual cycle, of the ovulation. Now, understanding the shedding of the endometrium through cervix. What does that mean? Cervix is basically very tight. That is, expulsion of the shredded endometrium is tough. What does that mean? Like if there is the cervix, wait, if there is the uterus, this is the endometrium. This is the endometrium. Now it may shed, but the cervix is so much narrow, almost you can say it is blocked. Okay, so this particular blood will, how can it pass? This is very important. So we will be understanding that the shedding of the endometrium through cervix. How is that possible? See, a lot of uterine contraction is needed for the menstruation. Okay, that means this particular uterine contraction is needed. Uterine contraction is needed, and also opening of the cervix is needed. So, a lot of uterine contraction is needed for the menstruation. This contraction is painful, extremely painful, and is called the period cramps. So, the female who suffers period cramp, it is totally natural, and basically it have a medical term which is called dysmenorrhea. So the period cramp is called dysmenorrhea. We will be using the term dysmenorrhea now on. Prostaglandin. Now let's understand one thing. See, basically what happens, This is the ruptured follicle. Okay, this is the ruptured follicle, and this is the oocyte. This particular is the oocyte. Now, these things you can see whenever a follicle is being ruptured. Whenever a follicle is being ruptured, it is more like an injury. It is more like an injury. As a result of injury, what will be released? Prostaglandins will be released. These are the prostaglandins. These are the prostaglandins. These prostaglandin will travel through the fallopian tube and will be getting embedded inside the endometrium to the uterine wall. Now what happens during the shedding of the endometrium? That means at the bleeding phase of the menstrual cycle, this endometrium sheds. This results the prostaglandin to get inside the uterine wall. As a result, this prostaglandin starts contracting the uterine muscles. So, this prostaglandin is the main important here, which helps in the uterine contraction vigorously. So, vigorous uterine contraction takes place and period cramp starts. So basically, what is dysmenorrhea? Due to prostaglandin are released due to rupture of the follicle, which is an injury, they get embedded, the prostaglandin get embedded on the endometrium uterine lining basically. These prostaglandin becomes dormant. They on the first day only they go, okay, like when ovulation took place, the prostaglandin will released because it is an injury. It is an injury to the follicle, isn't it? So the prostaglandin are produced in that particular day only. They travel to that particular site and they remain dormant till the time shedding happens. Shedding of the endometrium pushes the prostaglandin into the uterine muscles, and then these prostaglandin makes the uterine muscle contract, resulting in the opening of the cervix, which suffered as period cramps called dysmenorrhea. So basically, the contraction of the uterine wall took place. As a result, the cervix becomes a little bit open and the menstrual blood can shed out. Okay, so this is the mechanism where basically expulsion of the shredded endometrium take place. Now let's understand a new term. It is Mittelsmers. Mittelsmers. What is Mittelsmers? On the day of ovulation, during rupture of the follicle, follicular artery bleeding take place. Now, what is follicular artery? This is the follicle which will be made up of various arteries. This is very normal. It will be made up of various arteries called the follicular artery. Now, during the rupture, follicular artery will be also ruptured. As a result, some blood. As a result, some blood will be leaking out. These blood will be get collected where? These blood will be getting collected in the pouch of the Douglas. Anatomy you have studied, which is the pouch of the Douglas. This will be getting collected here. As a result, the person will be suffering from pain. That particular pain is called the pain of ovulation. Another term is Mittelsmers. Remember the term Mittelsmers. Its duration is 12 to 24 hours. Very mild pain, not so much recognizable. After 14 days of menstruation takes place. After 14 days, menstruation take place, and then period cramp take place. That's different. Period cramp is different. Okay, that is dysmenorrhea. Now, ovulatory cycle. It is painful. Shredding is due to the progesterone withdrawal as usual because the a person is not getting pregnant. So corpus luteum degenerates. The yellow fluid degenerates. As a result, no more supply of the progesterone, and hence shredding of the endometrium takes place. It goes on a regular cycle. But anovulatory cycle, what is anovulatory cycle? Anovulatory cycle is no ovulation takes place. Since no ovulation takes place, endometrium will grow. Why? Because it is in the follicular phase. So basically, estrogen is supplied continuously. But since no ovulation took place, that means no corpus luteum formed. As a result, no progesterone formed. As a result, endometrium keeps on growing. Okay, this is due to the supply of estrogen. Also, since there is no ovulation, there is no rupture, there is no prostaglandin formation, there is no Mitchell's mouse. But still, endometrium is keeping growing. Now, so what happens? In an ovulatory cycle, does there is no menstrual bleeding? Yes, there is menstrual bleeding. How does that takes place? It is very simple that when when the endometrium keeps growing, suppose this is the endometrium, this is the endometrium. It keeps on growing, it keeps on growing. The time will come when it will be no more getting the blood supply. As a result, due to ischemia, it will automatically break down. But the time is not fixed. It may be any time. That's why they are having irregular cycle, irregular period. Very important. There is no time of shedding, no specific time of shedding. The endometrium sheds due to ischemia. Guys, I'm trying to make the video as short as possible. Dysmenorrhea, I have already explained what is dysmenorrhea. Once again, I'm studying. It is the pain during the period. It starts half hour prior to the onset of the period and stays 10 hours post onset. Okay, the period time. This is called spasmodic or primary dysmenorrhea, which is the normal physiology. Spasmodic or primary dysmenorrhea. Then also there is a term existing called the secondary dysmenorrhea, which is always followed by a pathological situation. The secondary or the congestive dysmenorrhea is nothing but the pain starts 3 to 4 days prior to the menstrual cycle, and it is always pathologically associated. Basically, here the three diseases are given: adenomyosis, endometriosis, and the PID. PID is the pelvic inflammatory disease. Endometriosis is what? This is a diagram of the uterus where some uterine tissues are growing outside of the uterus. You can see some uterine tissues are growing outside of the uterus. This is called endometriosis. And what is adenomyosis? Adenomyosis is the endometrial tissue, endometrial-like tissues. Endometrial-like tissues means what? Here is the endometrium growing basically. Here the endometrium grows. So this endometrial-like tissues keep growing within the myometrium, which is called adenomyosis. Now the membrane dysmenorrhea. Membrane dysmenorrhea is a special condition. What happens in the uterus? In the uterus, the menstrual blood is always liquid. Have you ever noticed why doesn't it get clogged? Obviously, it should be clotting inside, but it doesn't get clotted because there is uterine fibrolysin. Uterine fibrinolysin, sorry, fibrin. Fibrin you have studied in blood clotting. Fibrinolysin. So the condition occurs due to the lack of the fibrinolysin. These uterine fibrinolysins keep it liquid. If it is absent, clotting will take place. And in membranous dysmenorrhea, actually, this is absent, so clotting takes place. As a result, the endometrium is shed like a cast of uterine cavity. What does that mean? If the uterine cavity is like this, then the clotting will be this shape. Okay, a circular shape. It may be a little bit oval shape, and the whole clot will be coming out itself like this. That's why it's called shape of the uterine cavity. Now, what are the treatment of dysmenorrhea? Now we will be talking about the treatment of dysmenorrhea. See, dysmenorrhea is totally normal. Okay. Huh. Membranous dysmenorrhea is pathological. Also, congestive dysmenorrhea is pathological seen in pelvic inflammatory disease, endometriosis, and adenomyosis. But dysmenorrhea, which is normal, the primary dysmenorrhea is totally normal, and obviously the pain is not so much bearable, but still it is physiological. So for the treatment, the first line drugs are the NSAIDs plus ibuprofen or naproxen or mefenamic acid. I don't know why mefenamic acid is preferred more. Okay, so you can Google it. Mefenamic acid plus NSAID is preferred. Or you can use antispasmodic drugs, which is dicyclomine or rotavirine. Combined OCPs, they induce anovulatory cycles. Now, using the combined OCPs, what happens? Basically, irregular period takes place, but also remember one thing. Combined OCPs induces anovulatory cycle. Now, what are the consequences of anovulatory cycle? Rupture of follicle won't take place. That means two things will happen. First of all, blood won't get into the pouch of Douglas. So, the condition, that is, Mittelmers won't take place. Another thing, that the pain of the menstruation is being reduced. Why? Because as there is no ovulation taking place, ovulation I mean basically no rupturing of the follicle taking place, prostaglandin won't be released. As a result, if the prostaglandin are not released, uterine contraction won't take place, so no pain. That is, dysmenorrhea won't take place. So it's a 21-day regimen pill basically. Another thing you can do is the dilation of the cervix under anesthesia. It is done by Hager dilator. It is an instrument. It is an instrument which looks like this. You can Google it. Gonadotropin releasing hormone analogs depot form. It is provided in the depot form. It causes downregulation of the pituitary gland. As a result, follicle stimulating hormone and luteinizing hormone are stopped. So periods are stopped. Presacral nerve ablation. Basically, you cut the nerve which carries the impulses of the pain. So you basically cut the nerve. Laparoscopic uterosacral nerve ablation, which is called LUNA, or by laser of the thermal methods, or by laser or thermal methods. Okay, so these are the treatment of the dysmenorrhea. But again, I think it is totally physiological. But in extreme cases, you can use NSAID plus mefenamic acid. First line drug is always preferred. 90% of the time, first line drug are only used. So thank you for watching.